The hospital floor is quiet. You're a new nurse, just months into your career, and the night shift feels endless. Suddenly, a harsh, desperate sound shatters the silence. You rush to your trach patient. He's panicking, gasping, oxygen levels plummeting. The monitor screams, 92%, 88%, 85%, each number is a countdown. Your heart pounds. This is real. You're alone. The charge nurse is busy elsewhere. In seconds, you must act. Training versus terror. You force yourself to focus. The patient's eyes plead for help. This is your test, knowledge, skill, and courage, all in one moment. What do? Before you can manage an emergency, you need to know the basics. A tracheostomy is a surgically created opening in the neck, with a tube placed directly into the windpipe, an artificial airway. It's a lifeline for those who can't breathe on their own, due to injury, illness, or long-term ventilation. Tubes vary: cuffed, with a balloon for a seal, vital for ventilators, or uncuffed for stable long-term users. Fenestrated tubes allow speech. Non-fenestrated do not. Always check the type, size, and care plan at the bedside. Essential safety gear: spare tubes, same and smaller size, obturator and suction setup, always ready. This isn't just a checklist, it's your patient's safety net. Suctioning a trach is a critical skill. Done right, it saves lives. Done wrong, it causes harm. Explain the procedure to your patient even if they can't speak. Pre-oxygenate if needed, then set suction pressure 8120 mmHg for adults. Use sterile technique. Insert the catheter gently, never suction on the way in. Meet resistance, pull back slightly, then suction as you withdraw, rotating the catheter. The whole process, 10-15 seconds max. The best rule of thumb is to hold your own breath when you apply suction. When you take your next breath, your patient also is ready to breathe. Pause, and let your patient breathe. Reassess immediately, check oxygen, breath sounds, heart rate. If needed, repeat, but always let the patient recover between passes. Suctioning is about being methodical and responsive, not fast. Back to the emergency. Your patient's oxygen is dropping fast. What's your first move? Calling rapid response is important, but help takes time. You must act now. Don't rush to change the trach or bag the mouth. Those won't help yet. The most common cause: a mucus plug. Suctioning is your highest yield, least invasive first step. You grab the suction catheter, reassure the patient, and insert it. You feel resistance, a thick plug. You suction, withdraw, and clear the airway. Instantly, the patient breathes easier. Oxygen climbs. 3 trach emergencies: bleeding, mucus plugs, and dislodgement. Bleeding pink-tinged sputum is common, but bright red blood is a red flag. Could be a tracheal innominate artery fistula. Overinflate the cuff, apply pressure, and call for help. This is a surgical emergency. Mucus plug, sudden distress, low oxygen, can't pass suction. Try suctioning and call respiratory therapist. If that fails, instill saline and try again. Still blocked? Prepare to change the tube. Follow your facility's protocol on changing tracheostomy tube. Dislodgement. The tube is out, patient in distress. Call for help. Get respiratory therapist at the bedside. Can they breathe through mouth, nose? If not, use the obturator and spare tube to reinsert if the stoma is mature. Never force a new stoma. Always have spare equipment at the bedside. Recognize the emergency, act fast, and know your protocols. I had an experience with trach dislodgement where the trach was inserted in the wrong place and the patient had massive subcutaneous emphysema. So there were 2 red flags. One, it was very hard to deliver breaths using ambubag via trach, and second, the oxygen level is not improving. Your preparation and quick thinking. Stay calm, systematic, and ready. The best emergency is the one you prevent, and watch for early signs of trouble. Assess lungs, stoma, and trach ties every shift. Secure but not too tight, you should be able to slide one finger easily. Check cuff pressure with a manometer. 20-30 mm per mercury is ideal. Clean the stoma and inner cannula per protocol. Remove secretions, prevent infection. Prioritize humidification. Trachs bypass natural humidifiers, so use a heat-moisture exchanger or humidified oxygen. Dry air thickens secretions, increasing plug risk. Watch for increased work of breathing new sounds, whistling, gurgling, or a patient suddenly able to speak with a cuffed trach. Changes in secretions, color thickness, signal infection or dehydration. Document trends and communicate with the team. Non-verbal cues, restlessness, agitation pointing to the trach, can be early signs of hypoxia. Never ignore your patient's instincts. Your clinical intuition, built on careful observation, is your best tool for early intervention. Spotting trouble early prevents crisis. The crisis is over. The patient breathes easy, gratitude in his eyes, and action saved a life. Each challenge builds your confidence and skill. What once felt intimidating now feels familiar. You start to anticipate problems, act early, and trust your instincts. Every experienced nurse started here, nervous, unsure, but willing to learn. Keep asking questions, practicing, and seeking guidance. Thank you for watching. I hope I added value. Stay tuned and watch my other videos for more learning. Take care.